Now, there were quite significant changes in service in the day hospital. Payment by result arrived later in psychiatry than in the rest of medicine, and this meant that the trust that I was working for would be paid a tariff for each patient seen by our service. That's admitted and discharged, so it's a patient episode. And in order for the trust to make money, they had to apply the correct tariff to each patient. So they developed an interview and a computer program to set you would go and interview the patient to set the correct tariff to make sure that they'd get their money. And this became paramount. It became almost more important than seeing patients clinically. Now, these tariffs were attached to what they called service lines, just like in Sainsbury's. And patients had to fit into a service line rather than the service adapting for patients' needs. The trouble was that our patients had all sorts of difficulties and so belonged to different service lines. The reason that we were looking after them was because they were older patients. Now, old age psychiatry was set up in the early 1960s because it was clear that older people were getting a very raw deal in general services, having to compete for care with younger, more disturbed patients, a form of indirect discrimination. Now we were told that a separate old age service was direct age discrimination, and that there should be separate dementia services, which could then go on to be marketised, and the older people with other conditions should be managed in general psychiatric services. This then meant that they could now fit into the service lines, but of course the clock was completely turned back in terms of indirect age discrimination. It seemed as if old age psychiatry was to become dementia care, but then 30% of older people with dementia have depression or anxiety. A large number have what we call delusions or psychotic illnesses, and agitation and challenging behaviours. And the dementia services that they set up were not resourced to case manage. That means to look after these patients. They were only resourced to make diagnoses and signpost. So there was still need for a lot of what we call non-cognitive specialist care with these patients. Alongside this, patients had to be dealt with quickly because in psychiatry, time is money. And the more patients you could, in their terms, pull through your service line, the more money could be made. So it became very important that early on seeing a patient, a discharge date was set. But we didn't know the patient, so how could we know how long they needed? And anyhow, situations change in older people. They may become physically ill, they may lose somebody. It was all very difficult to do. And the answer seemed to be the recovery goal. Everyone was going to recover in their sense of the word recover. And the goal would be something set with the patient, such as being able to go to the corner shop or getting back in contact with a relative, that was achievable in a shorter time frame. This would then be the time for discharge and, of course, the receipt of the tariff. If they needed further goals, that would be a reason for a new referral and, I suppose, another tariff. Thus, business matters overtook clinical matters. Indeed, I have to say that the way I was being asked to work owed more to changes in Parliament than to any clinical skills I had learnt or research I had ever read. What was a service where professionals were allowed to develop relationships with patients where necessary, with seamlessness, that means seeing the patient through different areas of the service, it became fragmented with separate teams being set up, pulling patients through their own bit of the service and then moving them on to another team. Separate tasks for separate tariffs. And longer term contact and support was seen as engendering dependency rather than being helpful.